So, hi everyone, and welcome to episode number four.
I think it is.
Yep. And today we're going to talk about TB, and I have to put my hand up and say it's probably one of my weakest subjects in travel health. Not too hot on diphtheria either, to be honest. But fortunately, we've got Neil here today. Neil has got a background in paediatric nursing, background in public health, and was involved in TB programs in neonates in central London. Is that right?
Yep, that's all right.
So Neil's our expert on TB today. So first of all, let's just kick off with TB and, what exactly is TB, and let's get back to basics. What is TB and how do you get it?
So, tuberculosis, it's a mycobacterium,
Right.
that is passed on generally in the sputum of people. So it's bacteria that is in the sputum, so it's close proximity that's passed on with. The majority of cases of tuberculosis, they're pulmonary disease, so they're in the lungs. So often you hear that chesty cough, then that is one of the key signs and symptoms of tuberculosis. So it's widespread throughout the world.
Mm-hmm.
And it's historically we've had quite low rates of it in the UK in general, and they've been on the decline. Not such a case around the world.
Yeah. So like you mentioned, it's a bacterium. So it's based bacterial. So it is actually a treatable disease with antibiotics, and yet, I mean, I believe something like 1/3 of the world's population is infected with. And it's either with active or latent TB. So what do we even... I mean, that's a huge number. What do we even mean by latent TB?
Well, just before we get to latent TB, I just want to look about the fact that it's treatable. Yes, we generally class tuberculosis as a treatable disease. However, when we do treat tuberculosis, it's usually by multiple forms because over the years it is developed, and we actually need to use multiple forms of antibiotics to treat tuberculosis.
Quadruple therapy.
Exactly, yeah, and it's usually for very long periods of time. It could be months and years even to treat. There are some that are multiple resistant, so not only just use 4, you have to go further than that. You have to use even more types of antibiotics. And there's some which we know as the XDR-TB, which is extremely drug-resistant tuberculosis. Where very, very rarely do people survive that because there just isn't we don't have the antibiotics to do that. Right. So you picked up on latent or active.
Yeah. What's the difference between...
So ultimately, active is if you've got signs and symptoms of the disease itself. So if you're actively, you've got your chest infections, you've got that lung disease or other tuberculosis disease that are showing the signs and symptoms. Whereas latent TB is where the bacterium is in your body, in your system, but it lies dormant, okay? And it may not ever cause you a problem in your life. But it may, at a later stage, come out when your immune system's run down in old age. It may come out and become active again at some point.
And could you pass it on when you're having latent TB?
When you've got latent TB, you cannot. It's not. You will not pass it on when you've got latent TB. It's only when you've got active TB that you're going to be able to pass the disease on.
Okay, so we know it's effective around the world, huge population. It's one of the big 3, along with HIV and malaria as being the big 3 affect the world. But and we also know that it's generally reduced in the UK, but over the last 100 years or so. But how does it actually affect our travellers? Because we're obviously giving travel health advice where we're seeing patients travelling to different parts of the world, sometimes for work, sometimes holidays. How is it going to affect our travellers?
Well, tuberculosis, full stop, is a disease of poverty. Wherever there is poverty, and it can be relative poverty, so if anywhere you go in the UK, you've got relative poverty, you're likely to see higher rates of tuberculosis. Right. And that is reflected around the world, where we have countries that poverty exists to extremes, we will see higher rates of tuberculosis because of the way it's transmitted. It's transmitted by being in close proximity. So where you've got populations that are living on top of each other, where you've got families, 3 or 4 families living in close proximity to each other, where the immune systems aren't at their highest level because they don't have access to nutrition and the basic needs, that's where you're going to see higher rates of tuberculosis. So where it's relevant to our travellers is we see day to day more and more people going to much more diverse places around the world, which is fantastic. But at the same time, they're potentially putting themselves at higher risk. They're also going for much longer periods of time. So we know that length is a massive risk factor for travelling in those areas. We know as well that it's becoming more and more common with things like even like couch surfing, like homestays, like Airbnb even. Sure. They're living a lot more close proximity with the local population as well. So they're putting themselves in a higher risk.
But presumably, I mean, I remember working in hospitals before where we used to, if we had a TB patient, we would have to be in the room for more than 10 minutes before we would have to need to wear a mask. So presumably we really are talking about pretty close proximity and pretty long periods. Yeah. Most of our travellers are not going to be really...
No, a lot of them won't be. And you're right, it's those prolonged periods of time, and the longer time that you live with close proximity. We know that the majority of transmission of tuberculosis happens in the home. Mm-hmm. So you would think that the nature of the disease, a lot of it may happen in schools and things like that. But there's not much evidence behind that. But with regards to home life, that's where the highest risk actually comes. And like I touched on, there is... a lot more travellers these days are spending time staying in homestays and in those environments. But also there's a lot more volunteer tourism and things like that going on now, where people will go and work in high risk environments. Yeah. Hospitals will be a high risk environment because the tuberculosis disease goes hand in hand with many other diseases. So if someone is in hospital for treatment for HIV, for example, it's a disease which tuberculosis goes hand in hand with. So they're much higher risk of being put at risk of transmission of tuberculosis.
Yeah. Okay. So we had a question from the Travel Health Professionals Facebook group about the vaccine. Now, the BCG vaccines, the vaccine we've got for tuberculosis, and the question is, is it in fact not really that effective, and if so, is there any point in having the vaccine? So talk to me a little bit about the vaccine and how effective it is.
Right, so in the UK, the vaccine was given routinely up until 2005 to school-aged, about teenagers, about 14 or 15-year-olds, routinely to everybody. Was offered to anyway. That was stopped for a number of reasons. Well, the reason it used to be given at that age was because previously the data showed that the highest risk in the UK of pulmonary TB was for young adults. So it made sense to offer it to that group of people. But there was a couple of reasons why it was stopped. Firstly, the rates in the UK considerably dropped. And below the magic level, which the magic level, or the high risk level we class it as across the world, and this is an international category, is 40
per 100,000.
Per 100,000 people, yeah, exactly. And we dropped below that, quite significantly below that. So that's one of the reasons why it was stopped at that age group. Also, there was a lot of data about how effective the vaccine was. The vaccine's been around for over 100 years. It's the same form, and as time has gone by, the effectiveness of it, the research into how effective it is has shown that actually it probably isn't that effective at protecting against pulmonary tuberculosis anymore. The older you get. Having said that, the evidence also supports that it's very effective against TB meningitis.
Right.
Now, TB meningitis affects young children predominantly. The highest risk group of people for tuberculosis meningitis are young children, under 1, but also up to about 5 years of age.
So it's given to that group.
So it's given targeted to that group. So in some areas in the UK, so for example, London has specifically high rates of tuberculosis. So it's offered at birth to all children in Greater London because the rates are so high. Having said that, around the rest of the country, it's offered to higher risk children and high risk people based on their family history or their travel history and things like that.
So presumably then our rates of TB meningitis are actually quite low in the UK, but then the rest of the developing world, for example, they're quite high.
Yes, they would be considerably high, yeah, and because the disease is so severe, that's why that specific group has been targeted with that vaccine, because we know that the BCG vaccine is very effective against tuberculosis meningitis. However, the data is questionable on how effective it is against pulmonary TB. So
those vaccinated kids might grow up and still be susceptible to pulmonary TB, and we have incidents of that.
I'm sure. Have you got a scar on your arm?
I've got a scar on the arm.
I've got a scar on my arm. We probably are as protected against pulmonary tuberculosis as someone who hasn't had it, arguably.
Okay, it's that poor. We've got another question from the group here about the difference between. I remember before I had it, I had the 6 needle thing, the Heath test.
Yeah.
We've got these things called MAN2 tests, but we've got a question about the difference between these new tests, quantiferon and T-spot. So do you want to give us a bit of a summary of the difference between all of those things?
Okay, so I guess let's bring it back to our traveller. We need to assess if our traveller is high enough risk. So for example, we know that the vaccination schedule was finished in 2005 routinely. So anyone under around 25 isn't probably going to have had the BCG vaccination routinely. So if we have a traveller that's coming into you, say that they're going to be going off travelling somewhere, we need to make the decision if they're suitable for the BCG vaccination. So how do we do that? We have to assess what their risk is. So if they're likely to be going to, say, India, which is classed as a high-risk country, and they're going to be working in a high-risk environment, say they can be working in a tuberculosis unit in a hospital in India, and they're going to be there for a prolonged period of time. The NICE guidelines and the Green Book, there's slight differentiations, but basically the general rule is if they're going to a high-risk country, they're under 35 years of age, and they're going for a long period of time, which is deemed as 3 months, then they would be considered a high risk and therefore should be offered the vaccination on a risk assessment. So if they fit all those categories, what do we then do? Well, we have to screen them first before we can just give them the vaccination. And as long as they're over 5 years of age, then we need to screen them. And you've talked about the quantiferon, T-spot and MON2. The quantiferon and T-spot, they're both tests known as IGRAs, interferon gamma release assays. Don't need to worry about that, but basically they're a blood test.
Good.
And T-spot and quantiferon, they're the only 2 commercially available IGRA tests that we have in the UK, and they've both got their benefits and strengths and limitations, but in reality, they're both accurate enough for us to use. So ultimately, it doesn't really matter on the evidence that we have whether you use a quantiferon test or whether you use a T-spot test.
And to measure whether or not you have TB, is that
yes.
right?
So basically, that test it's a screening process. So if you get a negative result from that test, it would indicate that you're very unlikely to have tuberculosis, and therefore would be suitable to have the vaccination. Yeah. Similarly, the MON2 test does a very similar test. It's testing to see if you've had the BCG before, but also to test if you've got active tuberculosis.
Right.
So if you had a negative result in that as well, it would also indicate that you could be offered the BCG vaccination.
Right. Okay. Right, so
is that clear?
Well, yeah, it's complicated stuff, but yeah, effectively the blood tests, the T-spot and the quantiferon are measuring whether you have active or latent TB, whereas the MAN2 was to a certain extent measuring whether or not you'd had the BCG vaccine. So they're looking at different things.
Yeah, it's slightly different things, but ultimately what we need to remember is that with the new NICE guidelines that came out in January of this year, actually, they talk about the IGRA test and MON2 basically in whereas previously they'd focused all about the MON2, they've accepted now that the IGRA test is probably a more sensitive and more accurate test.
Right.
So they talk about the MON2 and the IGRA test hand in hand.
But they acknowledge that the blood test is more accurate.
Yeah, exactly. Yeah. The blood test is more accurate. On that point, what we would recommend as well from the NICE guidelines is that the MON2 should still be used for under 17-year-olds as the primary screening tool,
Okay.
rather than the equal test. There's been a bit of evidence around the accuracy of blood tests with under 17-year-olds. Sorry,
Yeah.
so we really should be using the Montu for under 17-year-olds.
Okay. So this vaccine, the BCG, which isn't necessarily that effective for the types of TBs we're looking at these days. Is there any more hope? Are there other vaccines? What's the situation there?
There's about, I forget, I think there's about 7 or 8 now in testing.
Oh, right. Okay.
They've been tested, and they're all at different stages of the testing cycle. There's some quite promising results from a number of them, and they're at taking different approaches. So you've got one which is very interesting, is another live attenuated vaccine, which
So the MTB vac one I saw.
yes, yeah.
Right.
And that is being designed as a direct replacement for the BCG vaccination. There's quite a lot of positive information, data coming out about it. Then there's other vaccines that are being developed that are being trialled as a booster to the BCG vaccination, because with the BCG vaccination you only have one in a lifetime. There's no benefits of having a further vaccination, so you only have one.
This could boost the BCG.
Yeah, so these ones could boost that vaccine. Yeah.
Right. Sorry about that, folks. Okay, so there's hope for other vaccines. Yeah, well, that's good. That's promising. That pretty much wraps up my questions. Is there anything else you wanted to mention about TB?
I think one of the things with our travellers that we have to think about is that the Green Book guidelines are split into 2 categories when we're talking about tuberculosis. We're talking about occupational health and we're talking about travel. There is an element of overlap sometimes with our travellers. So, for example, you might not put someone in a high risk group if you just follow the traveller guidelines. But when you look at the occupational health guidelines, they might actually be going to put themselves in a high risk environment, and it might not be that they're there for 3 months, but they might be putting themselves, for example, working in a tuberculosis unit. And therefore, under occupational health guidance, we would be, if they were doing the same in the UK, we would be offering them the vaccine.
Anyway.
Yeah. So I think there's some grey areas which we need to be thinking about. Is that, yes, we're thinking about travellers, but we need to be thinking sometimes, what are they actually going to be doing? And this all comes into our risk assessment when we're travelling. What are they actually going to be doing over there? And if it falls into what might be classed as an occupational health category, then maybe we need to then look at the occupational health guidance, which gives you more leeway on what should be offered.
Yeah.
Ultimately, the question has to be, if the BCG is not a particularly effective vaccine, why are we offering it? We're offering it because sometimes it's better to have something rather than no protection at all. Yeah.
Okay, excellent. Well, that's certainly enlarged my knowledge on BCG and TB generally. So thank you very much. And I hope that's been helpful for everyone. Thanks to Neil.
No problem. Any further questions, please feel free to comment on our Travel Health Professionals UK Facebook group, and
ask Neil, and he'll be able to answer you.
Open up the discussion.
Okay, thanks very much. We'll see you next time.